enough to give up his time for the second incidence and deliver us a revision session based on the ECG and some pathologies. So what we were planning on doing is I'm going to share some slides and Dr. Broadhurst is going to take us through them. If you have any questions surrounding the topic that we're covering at that time, then please feel free to raise your hand. Dr. Broadhurst has said that it would be great if we could see some faces and hear some voices. So please don't be shy. You know, it's not a lecture. You're not going to get into trouble for getting anything wrong or asking questions. Ask questions that are relevant to what we're going through at the time. If you have any general questions surrounding maybe the ECG or cardiology in general, then if you could leave those to the end. You can pop them in the chat and I'll monitor the chat, but we will leave them to the end. So be aware that we're not ignoring your question. We're just going to leave it to the end so we get through all the ECG content that we want to. So I will go and share these slides. And if you let me know when you can see them.
I can see them.
Perfect. Amir, can you see them as well? Just as a
yes. There they are.
Perfect. All right. So yeah, I'll keep my camera on so you're not speaking into the void, Dr. Broadhurst. But
Thank you.
Yeah, over to you.
Well, thanks very much, Cameron and Amir, and the other members of the CAPS-SOC Society, University of Buckingham. I don't know if any of you have met me before, but I did do a session earlier in the year, I think over the summer, on heart failure, if I remember correctly. So I've been asked to talk to you briefly this morning on the ECG, and it is a quite a complicated subject, and it does take quite a lot of effort to fully understand. But once you've got the basics right, it is something that all falls into place. Now, I'm a cardiologist up in Aberdeen, which is near where Cameron comes from. So that's where the connection has arisen. I knew Cameron before he went to university, and I'm a cardiologist, and I also specialize in rhythm disturbances of the heart, an electrophysiologist. So to me, the ECG is probably the most important investigation on a day-to-day basis that I do, and that is above and beyond, coronary angiography and all these other things. So I'm going to try and keep it fairly basic and simple. Next slide. I think you missed. Did you miss one? Yeah. Actually, Cameron, are you sharing? I think you're sharing the wrong set of slides.
Right. Let me.
I think I sent you some others. I changed the order and added one or two extra.
Yeah. Let me just.
If there's a problem, I can share them from this end.
No, not at all. I'll sort it out. I'll stop presenting these.
Well, while he's doing that, the next slide was simply to mention to you all a book that it's called the ECG Made Easy, and it's not written by me or anybody I know, but it was a book that I got when I was at your stage of my training. I got it as a medical student, and even then it was in its second or third edition, written by a chap called John Hampton from the University of Nottingham. I suspect he's dead now, but the book is still going strong, and it's on its 18th edition, and you can get it from I think it was published last in 2019, and it's a wonderful book at explaining in very clearly this sometimes rather difficult to understand topic. So that's my second slide. I think the third slide was just to describe or show the various components of the ECG. The ECG is a recording of the electrical changes generated by the heart on the surface of the body. the heart is a pump. It contracts, the atrium contracts, then after a fifth of a second approximately, the ventricle contracts with flow of blood going through the right and then the left side of the heart, determined by valves shutting and opening. The atrium, when it contracts in response to electrical signals that pass through the atrium, and this generates the P wave on the surface ECG. Have you got the ECG up? Have you got the slides yet, Cameron?
They should be. They're loading now. Okay. I uploaded the wrong set, so they should be open now. Let's see.
Next one.
Yeah, I think this is the right set. Right. Okay. So next one. There we go.
Next one. Sorry. Next one. So this is what you see on an ECG. So you see all these deflections. There's a very low amplitude, low frequency deflection called the P wave, and this reflects atrial depolarization. This delay between the P wave and the next large deflection, the QRS complexes, reflects the PR segment. This is the PR interval, and this is the time it takes for an impulse to travel through the atrium and through the AV node. The AV node is the route through into the ventricle. The atria and the ventricles are electrically insulated except through by the AV node, and there's a delay of about up to a fifth of a second in the transmission of the signal through the AV node, and this gives rise to this PR interval is up to about a fifth of a second. This large deflection, the QRS complexes, is the next deflection that you see. It's much larger and higher frequency because it happens extremely rapidly, because it uses the His-Purkinje system to activate the left and the right ventricles almost simultaneously. And because the left ventricle is a much thicker bit of heart muscle tissue compared to the atrium, the signal is much larger. The larger the signal, usually the thicker the heart muscle at that point. And then you get ventricular repolarization, and that's reflected by the T wave, another low amplitude, low frequency signal. The atrium depolarizes, but it causes a low amplitude signal. It's usually, you can't see it because it's occurring at the same time as ventricular depolarization. Next slide, please. Now, that's what you see on the ECG, but the ECG machine, no, sorry, previous slide, but two. And then one before that. So this is a cartoon of somebody having an ECG, and you can see that there's 10 electrodes placed, 6 on the patient's chest and 1 on each of the patient's limbs. And by doing this, you can make an ECG recording, but sort of looking at the electrical changes of the heart from different perspectives. So, for example, the chest leads are looking at the anterior aspect of the heart and the way of depolarization and repolarizing from from the front of the chest. And the limb leads look at the inferior surface of the heart, and the leads 1 and AVL look at sort of electrical activity as if it's looking from the left shoulder. So we're looking from different angles at the heart when we're recording an ECG and generating these 12 ECG leads. Next slide, please. Next slide. And just to remind you that the heart is, this is what's happening at a cellular level, particularly with regard to ventricular depolarization. What's happening is there's sodium and potassium, and to a less extent calcium, going in and out of the cell very rapidly, which generates the electrical signals that you see on the surface ECG. Next slide. You can get a bit hung up on all what is normal and what is abnormal. You have to look at hundreds, maybe thousands of ECGs to be able to confidently look at the 12-lead ECG in about 5 seconds, say that's normal. Otherwise, you have to make a lot of measurements and go about it in a very systematic way, looking at the heart rate, the height and duration of the various deflections that you see. And these roughly are what reflect normal measurements of the P wave duration, P wave height, PR interval. etc. But it is a skill that is very important to acquire and is only acquired by quite a lot of hard work and looking at lots of ECGs. If you don't understand ECG, ask somebody who does, which is somebody usually with more experience. Next slide. This is a normal ECG. So you can see here that there's a sweep speed. The ECG is recorded at 25 millimeters per second usually. In electrophysiology, when we're doing ablations and things, we're looking at the ECG from inside the heart, and we're recording the signals at much higher sweep speed, maybe 100 or 200 millimeters per second. But on a 12-lead ECG, it usually looks something like this. So you can see along the bottom, you generally have a rhythm strip for about 10 seconds. But if we're interested particularly at the whole heart, and not just the heart rhythm, you have to look at all 12 leads and examine them carefully to make sure they're normal. You can see in lead AVR, which looks at the heart from the right shoulder, everything is upside down, which is normal because depolarization is generally moving away from the right shoulder. The sinus node is high up in the right atrium. Depolarization takes place from the base of the heart towards the apex. So everything is moving away in lead AVR. Next slide. How do we work out what the heart rate and rhythm is? Well, the business about the rhythm at the bottom, it's certainly important, maybe a bit more important in times of yaw to worry about whether a pulse rate is regular or irregular or irregularly regular or regularly irregular, because sometimes these things would suggest a particular rhythm diagnosis, such as atrial fibrillation. But nowadays, with ECGs readily available, this is less relevant. You can have irregular heart pulses, which are not due to atrial fibrillation, due to, for example, ectopic beats. But certainly looking at a 12-lead ECG of an arrhythmia, suspected arrhythmia, it is important to establish whether it's in regular or in irregular rhythm. If you want to calculate what the heart rate is, there are a number of ways of doing it. If you have a 10-second recording at the bottom of your 12-lead ECG, as we saw in that normal example, you can count the number of R waves, and then you multiply it by 6 to give you the heart rate. Or you can work out what the number of large squares intervals between each R interval or PP interval in terms of large squares and divide it by 300. Next slide. So here you can see that in action, the latter one. There's 4 large squares between 1, 2, 3, 4. But in the top example, there's 4 large squares between each RR interval or PP interval. So if you divide 300 by 4, you get the heart rate, which is 75. And in the bottom one, there's 5 large squares. By and large, if the heart rate's less than 50 or 60, we might say it's a bradycardia, and if it's above 100, it's a tachycardia. But these can be quite physiological. It doesn't imply a specific diagnosis. Obviously, if the heart rate's 20 or 180, and the patient's sitting there doing very little, then it's much more likely to be pathological. So next slide. Now, one of the key things you need to know about when you're a junior doctor, particularly, and you're dealing with lots of emergencies, is diagnosing myocardial infarction, which can generate arrhythmias. But the consequences of an occluded coronary artery is that you get heart muscle death, and initially you get repolarization abnormalities and subsequent development of Q waves if the coronary artery is left blocked. And because the ECGs, as we said, ECG leads generally look at different perspectives of the heart, we can guess roughly or have a good idea which artery is going to be blocked when we take the patient to the cath lab to unblock the coronary artery. You get ST elevation, by and large, if you block your LAD or your right coronary or your circumflex artery. And your right coronary artery generally supplies the inferior surface of the heart. So you'll see ECG changes on those ECG leads that look at the inferior surface of the heart, which is the leads 2, 3, and the AVF. The LAD, which is often the largest or supplying the largest territory, if that occludes, then you'll get ST changes usually in more than V1 and V2. It's often V1, 2, 3, 4, and maybe all the way across the chest out to V6. The circumflex artery subtends the posterior wall of the heart usually, but if it's large, in the way that it's developed, it may supply the inferior surface of the heart. And if it supplies the inferior surface of the heart as well, you'll often see changes in leads V5, V6, as well as the inferior leads, maybe one in AVL. But if it's just supplying the posterior wall of the heart, you just might see ECG changes in leads 1 in AVL, V6. I wouldn't get too worried about that, but what you need to spot is pathological ST elevation and know that this could be a heart attack, particularly when the patient's got chest pain, and act accordingly. Next slide. So we'll show some examples of some of these things. And this is where I think I'll ask some questions here. So next slide. I'm not responsible for some of these I mean, any of these cases actually. I'm not going to say who is, but here, for example, this is a guy who's 55, who's got 4 hours of central crushing chest pain. He's sweating, feels as if this is it for him. Sense of impending doom. And you're working in casualty in Oban. You get called from the medical wards to look at this ECG. So who's going to take a punt at what this shows? Other than Cameron or any of the people who know these slides.
Anyone, feel free to put your hand up or pop it in the chat. Prefer to put your hand up and just hear a voice, but if you're not comfortable with that, then just use the chat.
What about if I ask somebody whose initials are up here? That's too harsh.
That's fine. No, go for it. Go for it.
AS, it's flashing.
Am I good to speak?
You want to have a go? Show us your picture. Let's see your face.
I've actually got some building work going on around me, so I can't turn it on. Yeah. Am I okay to just speak, if that's all right?
Yes, you are.
Is it an inferior wall MI?
You sound a bit tentative. What about changes in V1, V2, V3, V4?
So you got ST elevation.
Yeah.
You've got an ST depression in V2 and V3.
Yeah.
You have ST elevation in 3, AVF 2. Yeah. So I thought it was an inferior wall MI, but I'm not so sure.
What rhythm do you think it is?
Sorry?
What rhythm do you think it is?
A rhythm.
Yeah. Is it sinus rhythm or is it
it's regular. It's regular sinus rhythm, I think.
Yeah, what about the rate?
The rate, it's about 60 beats per minute. 50 beats per minute, sorry. 50.
Yeah.
Yeah.
Uh-huh.
Yeah.
You're doing very well. Is there any other abnormalities? Anything else to comment upon on the ECG?
Normal axis deviation. No, sorry, I'm not sure.
Okay, well that's very good. You're completely right. I mean, the patient's got a sinus bradycardia, and they have inferior ST elevation and what we call reciprocal ST depression in other leads. So in the clinical picture, this patient is having an inferior myocardial infarction. The reciprocal ST depression is in V1 and AVL and V2, V3, V4. There's also a right bundle branch block, which is not particularly relevant to what's going on here.
Yeah.
So, Amir, so he's made the diagnosis for you. What treatment would you think about? Patient's got a Venflon in. The nurse have put a Venflon in. They've given him some morphine and some aspirin. What else would you do?
So I would give nitrates, GTN, IV GTN, and possibly think about thinking about oxygen. But we might be a bit careful with oxygen with perfusion injury, but it could be an option. I guess then we would decide on PCI or fibrinolysis, depending on if PCI is if we're. I think the window is 2 hours.
Window for what, PCI?
To do PCI or fibrinolysis, if you could get the patient to the hospital before 120 minutes, I guess, if I'm not wrong, then we do a PCI. If not, then we could go for fibrinolysis.
Well, you're quite right. This is completely correct. Aspirin, the patient's already had pain relief. It's very important. The patient is hypoxic. When you've got pulmonary edema, give some oxygen, nitrate, but it might drop the blood pressure. But thrombolysis or PCI and revascularization is indicated here. He's a young guy, and if you can get him to a PCI lab, depends on where you work. That determines what you can and where you're working. That determines what the patient's going to get. But I think from where you live, you should be able to get this patient to a hospital with a primary PCI service 24/7. So that would be the best treatment for this patient. Fibrinolysis. I said at the beginning that the patient presented to Oban, which is a little town on the west coast of Scotland, which is very rural, and he might not be able to get to a PCI. The nearest PCI service would be in Glasgow, and if it was felt that they couldn't get the patient to that hospital within 2 hours, that's certainly our sort of cutoff here, then they'll get thrombolyzed and then sent to Glasgow in case they don't reperfuse. So somebody sends something about what's happening in V3. There's ST depression. There's ST depression quite widely, and you sometimes see what we call reciprocal ST depression. But the dominant feature in other leads, but the dominant feature here is the ST elevation. That's certainly very much the way the patient is feeling. They often can get a bit vagal and they can get bradycardic, and if they get hypotensive, then and they get much slower than this, sometimes we might give some atropine, small amount of atropine, which might speed the heart up if they're hemodynamically. Okay, any other questions about that? Thomas Muldoon.
I don't know if you can see me. Hi. No, I just had a question with regards to, you said it was reciprocal depression. How would you tell the difference between, if it was like, can you get reciprocal elevation sometimes, or how could you tell?
We don't tend to. If you see ST elevation in this particular context with ST segment changes, it's nearly always a blocked artery. Okay.
Yeah.
And you don't. The only time that you might see ST elevation that you think is maybe less relevant is perhaps if you see it in lead AVR. But when you see this sort of ECG in this context with the patient continuing to have ischemic type chest pain, they need a coronary angiogram. If you saw this ECG without ST elevation in inferiorly, but all this ST segment changes in V1 through to V4 and 1 AVL, it could reflect a posterior wall MI. If you put the ECG leads around the back of the chest, so-called V7, V8, V9, you might see ST elevation there. The big difference was if this was just ischemic ST depression, it may go away with GTN. Then blocked arteries they don't unblock unless it's due to coronary spasm with GTN. But if there was no ST elevation, you could see what happened with your GTN. pain went away and the ST segments went away, this could be just unstable angina. But this is quite unusual.
Okay, cool. Thanks.
Next one. So he's making an uncomplicated recovery from following his primary angioplasty. He gets sent to Glasgow. His right coronary artery is unblocked. Gets sent back to Oban to continue his holiday during the pandemic. And it's noted on the in hospital on day 3 that his ECG is showing this particular abnormality. What is going on here? What rhythm is this? What about MB? Do you want to have a go? Is this sinus rhythm?
Hi. I would say it looks like sinus rhythm with the 10 squares in between the 2 R's. So which means it's 30. So he's very bradycardic.
Oh, 10 squares.
Is it? 1, 2.
Well, there's about 15 little squares.
Yeah.
But there looks to me as if there's about 3 large squares.
Okay.
So if you divide 300 by 3, you come to a rate of about 100. So this is about, a borderline sinus tachycardia.
Oh, okay.
Not slow. It's a little bit on the fast side, but not pathologically so. Is it completely irregular? You can see P waves. You can see P waves before each QRS, but then every 4th QRS is different in morphology. Is there a P wave before each different morphology QRS?
There is a P wave before, so the PR interval, it's reduced significantly. So does that mean that it's the morphology of the P, is it like a double? Is the P like an M?
Yeah. I think maybe you're looking a little bit too much into that. This is a rhythm strip. It is a sort of quite complex P wave signal rather than, but if it's depending on how the leads are looking at the heart, I wouldn't worry too much about the morphology. The PR interval looks quite normal. It's my pointer won't show up on your screen, but Cameron, can you just put a pointer on the beginning of the P wave and the beginning of the QRS? You'll see that there's more than 3 small squares, so the PR interval is normal. But after 3 normal narrow QRSs, there's a positive deflection. There's no Q waves there. All right, there's initial R wave, but there's a positive deflection that is not preceded by a P wave, much broader, and repolarization is different to what it is prior to each sinus beat. So when you see this broad QRS not preceded by a P wave, this is a ventricular ectopic. This is what ventricular looks like, and it looks like this because the ectopic focus is firing, depolarizing from within the ventricle and is activating the ventricle out with the His-Purkinje system. So when depolarization takes place normally via the AV node in sinus rhythm, the right and left ventricles are activated very rapidly by the His-Purkinje system. But if you get an ectopic beat that's arising out with it, it just spreads via the intercalated disc between each myocyte. So it takes longer for the ventricular depolarization to take place. So you get the QRS much broader. And because depolarization is abnormal, repolarization is abnormal. This is what ventricular ectopics look like. And if you took the patient's pulse, you would probably notice some irregularity. Next one. This is on the same kind of topic. Who wants to tell me which artery is likely to be blocked here? Mariam, you there? Do you want to hazard a guess? V1 looks normal. V2 is a lot of ST elevation, and V2 out to V4, and maybe in 1 and AVL. Which artery is blocked?
So it would be LAD.
Exactly, that's it. LAD is occluded. You see this patient, particularly the patient who's having a myocardial symptoms compatible with myocardial infarction. They've got continuing chest pain. There's an indication for the patient to be revascularized by PCI if at all possible. Does anybody know why PCI thrombolysis?
Contraindications are a lot, I think, with fibrinolysis, PCIs. I think it has a better prognosis, definitely.
Yeah, I mean, you can achieve the end, which is opening up the artery much more reliably. The thrombolysis is okay, but it only opens the artery up in 75–80% of the patients. And you also expose the patient to a 1% risk of major bleeding, which could be intracranial. So it's better to use thrombolysis if there is no other option, but better still is primary angioplasty. Next slide. LAD occluded. Okay, so this guy is 73, goes to see the GP with dizzy spells and breathlessness. What's happening here? Anybody want to describe what they're seeing? And it's appropriate at this stage, probably, rather than to look for the diagnosis, to go about systematically looking at the ECG. First thing you do, actually, is to make sure the ECG is given to you, correct ECG, okay? Got the right patient's name on it. Sometimes ECGs get muddled up. Got Ralph Goose Chase looking at somebody else's ECG, and you can even make wrong decisions about that. So check that it's the right ECG, and it's the ECG that you want to look at, the most recent one, for example. And then look at the rhythm. Look at the P waves, PR interval, the QRS complexes, the ST segments, and the T waves. To them all the ECG leads, not just the rhythm strip at the bottom, all the ECG leads. So this is maybe a little bit more complicated. Patient comes up to hospital. Everybody who comes up to hospital with some cardiological abnormality these days seems to be assessed for myocardial infarction, but he's just got dizzy spells and shortness of breath. Anybody think he's having a myocardial infarction?
I think Victoria had her hand up there. If you want to.
Oh, did she?
Yeah,
Victoria.
Yeah.
Yeah. Hi. Sorry.
Hello.
So I was just going it like I was going to it like how you were saying, like in the order.
Yes, good.
So like we can see that the patient has a sinus rhythm. We can see that there are some P intervals followed by a QRS complex on lead 2. So with regards, because there's no squares here, could we do the could we count how many R complexes they are and times that by 6 to get the rhythm?
Yeah, I mean,
So,
what would you say the sinus rate would be here, roughly, just looking at it? Do you think it's a slow heart rate or a fast heart rate?
I would say it's
This
a
is 10
slow heart rate.
Yeah.
So it's
So
bradycardia.
according to the number of QRS complexes that you can see here, I seem to have a Cameron Stevens send a quick message here. According to that algorithm, the heart rate's about 40 here, because there are how many QRS complexes across the bottom?
7. So 7 times 6 is around 42.
There's 42. So the heart rate is 42. What do you think the sinus rate is? P waves than there are QRS complexes.
Sorry, what did you say?
Are there as many QRS P waves as there are QRS complexes?
Yeah, there's a QRS complex after every P wave.
Well, that's not quite true. Cameron, if you just point
Is it
to
not?
each P wave, Cameron, just with your pointer, point to each P wave and demonstrate to me the P waves that you can see.
I can't seem to get a pointer up, but I can see what you mean.
If you see in the rhythm strip at the bottom, halfway between the first two QRS complexes, there's a P wave. Can you see that?
Yeah, but isn't that
before the next QRS
also
complex,
with
there's another P wave, and after the T wave, after the second QRS complex, there's a P wave. And then with the next QRS complex, there's no P wave, or there's just the beginning of a P wave buried in the QRS complex. And then after that, there's another P wave. The next QRS complex doesn't have a P wave. There is no relationship between the P waves and the QRS complexes. There are more P waves than there are QRS complexes. And if you look also at lead V1, for example, the QRS complexes are quite broad. You can't really say how broad they are because the little squares are not come out on the ECG. What is the diagnosis when there are more P waves than QRS complexes and the QRS complexes are very slow? You know what the diagnosis is? So the sinus rate is not influencing the ventricular rate. There is a condition called
So
what?
is it third-degree heart block?
Absolutely. Complete heart block. This is complete heart block. Okay. So if this is not reversible, it's not due to drugs or some rare condition such as Lyme disease or something, what is the treatment of complete heart block, particularly when it's symptomatic? Probably even when it's not. Anybody know? Cameron will know this. Thomas, what is the diagnosis? What is the treatment?
Would this be cardioversion?
No.
Like a shock? No.
No. Cameron, you'll know this. You've seen
pacemakers.
lots of these things.
A pacemaker, wouldn't it?
Yeah, it's a pacemaker. Probably a dual chamber pacemaker and sometimes a 3-chamber pacemaker, but a pacemaker because the heart rate will not rise. And the ventricular escape rhythm that you're seeing can be unreliable and can fail, and then the patient will black out. So you can see here that Cameron's put on this ECG, he's pointed out all the P waves. You can see there are more P waves than there are QRS complexes, and no relationship between the P wave and the QRS complexes. So often the QRS complexes are dead regular because there's an escape focus firing off within the ventricle to keep the patient's heart rate going, albeit at a slow heart rate. Any questions about that?
I have a question. Could we not give atropine during third-degree heart block?
You could try, but it was not going to have any effect other than the fact you'll probably speed up the sinus rate. There are certain circumstances in which atropine will be effective, but not usually in this sort of scenario where the patient is symptomatic, it's occurring spontaneously, and it's not occurring in the context of, for example, the inferior myocardial infarction. The QRS is very broad, which suggests that the conduction block is not just within the AV node, it may be below the AV node, and atropine will not affect that. What it will do is cause more of a sinus tachycardia, so the sinus rate would accelerate. You could try it, fine, and sometimes people give isoprenaline to try and increase the rate of the ventricular escape rhythm, but usually this doesn't work, or just has a temporary effect, and the patient ends up with a pacemaker. As I say, sometimes drugs will cause this. Sometimes it occurs in the context of an acute inferior infarction, and then it will just get better, It needs a pacemaker. Next slide. So bradycardia, so heart rate's usually less than 50, but even less than 50 can sometimes be quite physiological. I suspect some of you guys must be quite fit and take a lot of exercise and sport, and in that situation, the heart rate can be much slower than that, and when you're probably asleep at night, it could be down to 20 or 30 beats per minute. So physical conditioning will cause quite profound sized bradycardia, but if that is not the explanation, the patients are symptomatic when they're bradycardic. It could be due to a number of reasons. Drugs can cause some bradycardia, no question about that. But if the sinus node fails to depolarize at a physiological rate, you can get sinus, it's called sinus node disease, sinus arrest, sinoatrial conduction block. This can be symptomatic, and the patient requires a pacemaker to pace their atrium. Heart block, we've already mentioned, third degree AV block. First degree AV block is where the PR interval is just prolonged, but conduction from within the AV node is otherwise quite normal. And that is not an indication for pacing. Second degree AV block can be of two types, and we'll show you some of those in a minute. And then there could be more advanced conduction disease that doesn't necessarily yet result in heart block, but is it perhaps in some circumstances can result in heart block further down the line. Left and right bundle branch block. Right bundle branch block can occur normally. Left bundle branch block is often due to underlying heart disease of some description. And if you get branches of particularly the left bundle that don't conduct, you get what we call fascicular blocks. And these may, under certain circumstances, progress often over many years to high-grade AV block requiring pacemaker. Next one. So this is an example of Mobitz type 1 or Wenckebach block, where the PR interval just gets progressively longer, get more and more delay as the impulse tries to get through the AV node. And eventually here you can see with the second, third, fourth, fifth, sixth P wave, there is no QRS complex after the P wave. We measure out the PR intervals on the preceding P waves, sinus beats, you'll see the PR interval gets progressively longer. This can be related to drugs. It often reflects block within the AV node. The beta blockers, calcium channel blockers, Joxin can cause this sort of thing, and it can be quite normal. Again, very fit individuals can exhibit this even during the daytime, and if the patient is asymptomatic, we wouldn't necessarily do anything about this. It's very common, even in normal people, to have this, unfit people like myself, to have this at night when vagal tone is increased. It's often a manifestation of increased vagal tone. Occasionally we have to place this, but it's rare. Next slide. This is an example of Mobitz type 2 secondary AV block. So it usually isn't a sign. It can be related to drugs, but often is not much more likely to be related to disease below the AV node. And this is where PR interval remains fixed, but all of a sudden the P waves fail to conduct, particularly if it's occurring during the day and if the patient's certainly got symptoms. There's no drugs causing this. This would be an indication for a pacemaker. See here, the first P wave, the second P wave you can see, or the first P wave that's highlighted, not followed by a QRS. Normally, the second, third, fourth, and fifth P waves, the PR interval is normal. The sixth P wave, again, it fails. So often in this study, you'll find that there's a quite advanced His-Purkinje disease. Patients nearly always end up with a pacemaker. Next slide.
Very sorry, I just had a question about second degree heart blocks. What is the treatment for that if it's symptomatic?
If it's symptomatic, it depends. If the patient's dizzy and they're on 10 milligrams of bisoprolol, then stop the bisoprolol or reduce the dose and see what happens. Certainly, if the patient is symptomatic and there's a good indication and they've got Mobitz type 2 secondary AV block, they're going to need to be paced. They don't necessarily need to be paced as an emergency, but they're and if these patients present in this way, you'll often see, whilst they're waiting for their pacemaker in the coronary care unit, ECGs that are going between, maybe it's type 2 secondary AV block and another ECG which is a complete heart block. So they go between the two sorts. Need to be paced by and large. So what's this an example of? This is an interesting, not an uncommon situation to find this particular scenario. Cameron, not one of your slides. Tell me what two diagnoses you can see you can make here. The upper ECG.
On the upper one, so I can see that the rate is quite fast. So they're tachycardic. And then there is a prolonged period where there's no P waves or QRS complexes. And then after that, there's another prolonged one. So I'm unsure of the exact diagnosis, but they are, it's like they're in sinus rhythm and then they're out sinus rhythm. So is this progressing into cardiac arrest? I'm not sure.
Well, you would describe what you see, but anybody else come up with a more specific diagnosis? The stuff at the bottom is a load of, it's irrelevant, not correct. Anybody? This is so. No, it's not after giving amiodarone. So if you look at the top ECG, the QRS complexes are slightly irregular and they're fast. Okay. The patient has some form of atrial tachyarrhythmia. It may be atrial fibrillation, or although there are some organized segments which make me wonder whether there's some atrial flutter. And then suddenly, whatever's going on in the atrium, it stops. So atrial fibrillation or atrial flutter will stop, and then the heart has to depolarize spontaneously. Atrial fibrillation and atrial flutter are arrhythmias that are not generated by the sinus node, but they will be suppressing the sinus node. Electrical signals will be passing through the right atrium and invading and suppressing sinus node activity. So when the atrial arrhythmia stops, the sinus node has to wake up, and it usually does pretty quickly. But here you see it's a bit sluggish. The first QRS complex that you can see is preceded by a funny-looking P wave, which is probably a junctional escape beat. And then there's no sinus activity at all for 3.6 seconds. So this is sinus node suppression. And then the sinus node eventually wakes up and it depolarizes. And this is what we see not infrequently in patients who have paroxysmal atrial fibrillation. The patient's got paroxysmal atrial fibrillation or flutter, termination, it's got sinus suppression, and the patient is dizzy. What is the treatment? Well, it's best to try, if you by and large, if you suppress the atrial fibrillation or atrial flutter, usually by catheter ablation, they won't get this suppression anymore, and their dizzy spells disappear. From a clinical perspective, if somebody has dizzy spells and atrial fibrillation, paroxysmal atrial fibrillation, if they always ask them, when do you get dizzy? Do you feel dizzy and then you feel better? Is the atrial fibrillation gone at that point? And they'll often say it is. And this is the manifestation, this is the explanation behind it. It's the same sort of thing in the ECG below, which is much more obviously atrial fibrillation. It stops, and then you get sinus node suppression, and eventually after 3.1 seconds, the P waves start again. So the problem about giving antiarrhythmic drugs to suppress the atrial fibrillation is if they don't work, if you give amiodarone and it doesn't prevent atrial fibrillation, you'll just make the sinus node suppression worse. Sometimes from a pragmatic perspective, she's quite frail, we might give them a pacemaker and some antiarrhythmic drugs, but if they're younger, we'll do an ablation to prevent the underlying cause, which is the ablation of atrial fibrillation or flutter. It doesn't always prevent the problem of atrial fibrillation or flutter, so they sometimes still end up getting a pacemaker, but they're young, it's best to try and avoid a pacemaker. Next slide. Any questions about that? That's sinus node disease. Okay. Right. How many more slides are there, Cameron? 9. Okay.
Yeah, 9. Yep.
Okay, let's go to the next slide. Okay, well, one of the things that it seems to help doctors, this is not a very good slide, unfortunately, but it does illustrate one of the problems that you get. This is a patient I saw quite recently. Doctors tend to interpret the computer generated. There's an algorithm in many ECG machines that provides an interpretation of what's going on to the clinician, and certainly in general practice, this often is the only interpretation that is taken note of, and it can give rise to a lot of overdiagnosis, occasionally underdiagnosis. I've seen patients who had a diagnosis of atrial fibrillation that was incorrect. Here's one that's actually come from within the hospital, where a young man who was 18 had been told he has long QT syndrome. Does anybody know anything about long QT syndrome? It's quite a rare condition. It's long QT is what we call a channelopathy. It's an inherited condition in young patients. It can be acquired, can be due to drugs, but there's often a genetic defect in the potassium channel, occasionally the sodium and other channels, and repolarization is prolonged, and it can generate polymorphic ventricular tachycardia and even sudden death. So it's an important condition. It runs in families, and cascade screening of family members of a proband as an affected individual can allow us to reassure people who don't have the gene and will not risk of the condition, and obviously follow up and treat people who have yet to have any symptoms but are at risk of it because they have the gene and they have QT prolongation. So in about 80 or 90% of the cases where the individual is young and there is no alternative explanation, such as hypercalcemia or taking a drug, we usually find there's a gene. So this patient went to the geneticist and there was no gene identified. And so when they came to see me, the patient was old enough to leave the pediatric service and came to see me with this diagnosis of long QT. Now, the diagnosis was based upon the QT interval measurement, which is generated automatically by the ECG machine. And you can see I've squiggled it out. And it says it's 500 and something milliseconds. And over the years, ECGs have shown varying degrees of QT prolongation. The upper limit of normal QT is about 450. Now you have to adjust it for the heart rate, because the QT interval shortens at high heart rates and prolongs at low heart rates. But the machine will do that for you. And as long as it identifies the QRS segments correctly and the end of the T waves, the measurement's usually quite accurate, but you have to check it. The clinician who saw this patient and made the diagnosis and treated him with a beta blocker for a number of years read the QTC, but didn't make any measurements in itself. And one of the things that you do, you can spot when ECGs look normal and abnormal. And if the numbers don't fit, then you're often correct in being suspicious. So in fact, this particular individual, the the machine was wrong. What it did was, can you just advance the slides, because I've written something on here. Press, yeah. What the machine has done, the patient's got a short PR interval, which is another issue. It's not. The machine has incorporated the P wave into the QRS complexes, measured the QT interval from the onset of the P wave to the ends of the T wave. The T wave morphology looks quite normal. Patients with long QT, they have funny looking QT. I mean, T waves, they don't. The ECG doesn't look like this. This patient's got a short PR interval, but he does not have long QT. When you measure the QT interval manually and correct it for the heart rate, the QTC is 360 milliseconds, which, if anything, is a bit short. I mean, it's still normal. Okay. So when I went back and looked at every single ECG in the patient's notes where the QTC was prolonged, it wasn't. The machine had incorrectly ascribed the onset of the P wave being part of the QRS measurement. So the point about this is simply don't just read off the numbers from the ECG machine and take the interpretation as gospel. It is not. It can be quite abnormal. It might be correct, but if it doesn't look correct, measure it yourself. And certainly, you know, okay, I specialize in looking after patients with long QT and stuff. So, but don't be surprised if you get a letter back from a cardiologist that sometimes that if you've made a diagnosis based upon the machine, either the computer generated report or the numbers that are up on the towards the left-hand corner of this particular ECG, if the diagnosis changes. Okay, I've seen ECGs machines diagnose ventricular fibrillation as irregular heart rate, arm lead reversal, and all sorts of things. It's you have to be very suspicious about some of these algorithms. Next slide. Anybody like to fathom a guess at what this is? Well, it tells you at the bottom, actually. It's another example of complete heart block. Next slide. Next slide. Okay. So this is a 56-year-old guy getting chest pain and palpitations. He goes to hospital. Carotid massage is carried out to no effect. Do you think that was the correct thing to do, perform carotid massage on this man? Amir, what is the diagnosis, I suppose?
Just looking at it, it's fast, the rate, and the QRS complexes are wide. So I'm guessing there's a ventricular origin and ventricular tachycardia, maybe, because it's fast and it's from the ventricles. And the carotid massage didn't have any effect, so it's not SVT, it's VT probably.
Yeah, that's right. This is a broad. This is how you describe this. Is a broad complex regular tachycardia. The rate is about 160, 170. You can have broad complex tachycardias which are not ventricular. Under these circumstances, we look for evidence of association between the atrium and the ventricle, or when we suspect ventricular tachycardia, we look for evidence of VA dissociation. So we look for P waves, see if they're occurring independent of the QRS complexes. Okay, it's kind of difficult sometimes when the tachycardia is fast, but if you look in if all the ECG leads, not just the rhythm strip along the bottom, you might see a little deflection, P wave, that is not seen in the other lead, and not seen at the same position within the cardiac rhythm, which reflects independent P wave activity. If the atrial activity manages to get down through the His-Purkinje system into the ventricle and depolarize the ventricle before the depolarizing wavefront from the ventricular tachycardia focus or circuit, then you might see a narrow or an intermediate QRS complex, which is called a capture or fusion beat. So this is, if you see this, if you see a narrow QRS in amongst a load of broad QRSs like this is definitely ventricular tachycardia because there's evidence of AV dissociation, independent atrial activity. And if you can see P waves dotted throughout the QRS and ST segments, T waves, which are not related to the QRS complexes, again, that's atrioventricular dissociation and ventricular tachycardia. Now, you don't get this sort of stuff, this sort of information, even if you look very carefully. Ventricular tachycardia virtually is never going to stop with carotid sinus massage, by the way, prevaricating by doing that. But broader the QRS, the more likely it's ventricular, okay? And this is very broad. In this particular, the more extreme the cardiac axis is, more likely it's ventricular tachycardia. So this axis is really extreme, okay? It's negative in 1, 2, 3, AVF. So the axis is out towards probably about minus 90 degrees. The QRS is probably about 180 milliseconds. And I think also, you can't see, but in V6, deflection is negative. If the deflection is negative, it means the depolarizing wavefront is moving away from V6, which is towards the apex of the heart, which means this can really only be ventricular tachycardia. So there's a lot of things that point towards this being VT. And obviously, if the patient has underlying structural heart disease, that seals the deal. You can have ventricular tachycardia when there is no underlying heart disease, so-called idiopathic VT, but it doesn't usually look like this. So if the patient is compromised, sweaty, hypotensive, what is the treatment for this? Guys, you're sitting there watching him, having a conversation, he's starting to lose consciousness. What are you going to do to this guy? Medical emergency. Cardioversion, correct AF. Quite correct. So you have to cardiovert the patient. Difficulty is obviously in a patient who's not very well, compromised hemodynamically, but he's conscious. Under these circumstances, you need to get anesthetist down or administer some sedation and monitor the patient very carefully, because before they go out, become unconscious, cardiac arrest, you might need to cardiovert the patient. They need to go to coronary care unit, really. Sometimes we use drugs, but not where the patient is hemodynamically compromised like this. It doesn't work. The patient's hemodynamic status just gets worse. Next slide. What about this rhythm? I can't see Jacob Mogg drinking pints. He might have half a shandy, I suppose. But he's got palpitations. Not uncommon arrhythmia in medical students who've been out drinking heavily. What is this cardiac rhythm? Because of time, maybe somebody can proffer a diagnosis. Why, rather than go through the whole laborious. MB, what do you think it is? Or Victoria, you haven't said anything. NA says AF. What do you think, Victoria? Do you agree it's AF?
I'm actually not sure about this one.
Okay. Well, it is AF. If I say it's AF, why do you think we're saying it's AF? Just concentrate on the rhythm strip on the bottom. Can you see P waves?
So I'm not seeing. The thing is that I'm not seeing any I'm not seeing P waves before the QRS complexes.
There's no P waves. There's some kind of continuous electrical activity here, and if you look in V1, it's quite coarse. Okay, so there's an undulating baseline here. Okay, and the QRSs are completely irregular. certainly back here, completely irregular. So no P waves, continuously irregular electrical activation in the isoelectric line between the QRS complexes, irregular. This means atrial fibrillation, almost certainly. Well, this is atrial fibrillation. Any questions on that?
Hey, yeah, sorry. I had a quick question about this one. How would you treat it?
Oh, you're asking me my whole job here. Atrial fibrillation is a very common arrhythmia. Depends very much on the clinical circumstances. I think in somebody who's been previously well and this rhythm may have been provoked by some very heavy drinking, you could just give him a beta blocker and probably it's going to stop on its own. Okay, a beta blocker might slow him down a bit. He's not going that fast actually. Might make him a little less aware of the irregularity of his heartbeat, which is so distressing him. But it's quite likely to self-terminate. If it doesn't self-terminate, or it's done it before, it's not provoked, then you can cardiovert the patient, either using drugs or electricity. So class 1C drugs such as flecainide, either orally or intravenously, may terminate this. The thing about cardioverting patients when they present acutely, they have to have had the arrhythmia for less than 24 hours, 48 max for you to do this, because if you don't, then there could be a risk of thromboembolism by cardioverting the patient. So if the patient has been in this, say, for a week, based upon the history, beta blocker and maybe some anticoagulation, and at this age, in this setting, you would cardiovert the patient, but after a month of anticoagulation. That's how you'd manage this scenario. There are lots of other scenarios I don't think we have got time to go into, and it's a subject of a whole lecture. So that's how you'd manage I mean, if the guy's just not unwell but just doesn't know what's wrong, and you diagnose atrial fibrillation and he's okay, and you could send him home. And if it's say, look, if it doesn't self-terminate in a couple of days, come back or get your GP to refer you to a cardiologist. You need to be anticoagulated and cardioverted. Okay, there are some tests you might do, particularly if this is not provoked by skin full of booze. Thyroid function is important. Echocardiography be important to make sure the heart is structurally normal. Okay.
Perfect, thank you.
Yeah, there's 4 more slides. Let's see if we can get through those quickly. Next one. Ah, nice slide. So what is this? There's a gold star for this if you can get this. Describe to me what you're seeing here. Who's TM? Thomas, isn't it?
Yeah.
So this guy, this is a real case, and this guy's sitting in casualty, feeling a bit uncomfortable with some palpitations.
I'm really confused, but I'm just gonna guess like ventricular fibrillation. That's the only thing I can think of.
He's sitting there. He's not unconscious.
Oh, okay.
He wonders what all the fuss is about. There's a lot of people like you around who don't quite know what's going on because they haven't seen it before, and they're concerned the patient may. Why are they not in cardiac arrest? Because this looks a very angry-looking, unpleasant ECG. Anybody feel a bit confident? I wouldn't expect you to get this, but if I say to you, this is an irregular, a very irregular, broad complex tachycardia, what does that suggest to you that it might be? Irregular, broad complex tachycardias. This is atrial fibrillation. Okay, it's very irregular. Why might the QRS complexes be so broad, and in particular, very rapid? Look at the interval between these two complexes here. There's 5.5 little squares. The rate here is almost 300 beats per minute. This is what we call pre-excited atrial fibrillation. Do you know what I mean by pre-excitation? Have you heard of Wolff-Parkinson-White syndrome? Nodding of heads. So Wolff-Parkinson-White is quite an unusual condition. It is a developmental anomaly. It's not an inherited predisposition. By and large, in most cases, there's no inherited predisposition. But there's a bypass tract. So there's not just your AV node. There's an accessory pathway traversing or drapes over the atrioventricular ring. And this will conduct more rapidly, without any delay, into the ventricle compared to the AV node. And not only will it conduct more rapidly, the refractory period of the accessory pathway can be very short indeed. So, because it's inserted out with the His-Purkinje system into the ventricular myocardium, the QRS are very broad, and the ventricle can be depolarized very frequently and rapidly if the patient goes into atrial fibrillation. So in atrial fibrillation, there's 300 plus electrical circuits going crazy in the atrium, and they can't get through the AV node, which only conducts maybe up to 180, 200 beats per minute, because the refractory period of the AV node is relatively long. It's up to about 300. Here, the accessory pathway can conduct much more frequently than that. As a consequence, the ventricular rate can be very rapid. And this can predispose to ventricular fibrillation. If you leave this guy and don't do anything about him, he could go into ventricular fibrillation and die. Okay, so this is an indication, certainly if the patient is compromised, to cardiovert the patient electrically. But the patient will then show ventricular pre-excitation, and the penny will drop in the A&E department that the patient's got an accessory pathway. This is pre-excited atrial fibrillation. The patient should be admitted to hospital and have this accessory pathway ablated, if at all possible, prior to them going home. It's not a very common scenario, but once you've seen this, you don't forget it. And the patient, because it often occurs in people who are otherwise fit and well with structurally normal hearts, in most cases, may tolerate this. Not every single QRS complex is very soon after the last one. The RR intervals are relatively long here, but they certainly need to be monitored until they're cardioverted with electricity. If the patient developed this in the coronary care unit, and we didn't want to ablate them, and right away, we could give them some flecainide, which would probably restore sinus rhythm or prolong the refractory period. But this is quite advanced cardiology and would only be done, I think, by an electrophysiologist. So pre-excited atrial fibrillation, it does look a bit like ventricular fibrillation, but it's not, and the patient is too well for them to be in VF, or even ventricular tachycardia. Ventricular tachycardia is usually quite regular unless it's polymorphic. This is irregular. There's not really very much else this could be. Next slide. Right, my favorite person. Anybody know what this diagnosis is? This is a diagnosis that, again, is easy if you look at all 12 leads, but often is made on the basis of one lead, a rhythm strip. Anybody want to hazard a guess at what this is? Getting palpitations. Bless her. Yasmin.
Atrial flutter.
Atrial flutter, 10 out of 10, exactly. You can see continuous electrical activity between the QRS complexes, and there's a sawtooth pattern, almost looks like a shark's fin going along. It can be quite difficult to see this at higher rates. Here we've got atrial flutter with 3-to-1 conduction between the atrium and the ventricles. Often it presents with 2-to-1 conduction, and then the flutter waves can be less easy to discern, particularly if you only look at one ECG leads. What is the difference between fibrillation and flutter? Atrial fibrillation is a much more chaotic, disorganized arrhythmia within the atrium. You're getting multiple wavelets going around and around within the atrium, which are stopping, and other wavelets are starting up or being propagated, which cause functional block. It's a complex arrhythmia and gives rise to no real organized electrical activity on the surface ECG. Atrial flutter, which can coexist with atrial fibrillation, is due to an organized tachycardia. It's called a macro reentrant tachycardia. So in this situation with flutter, unless the patient's had prior cardiac surgery involving an incision within the atria, there's a flutter circuit going round and round, usually the right atrium, between the tricuspid valve, and it passes between the tricuspid valve and the inferior vena cava, and it generates an organized electrical signal wavefront propagating from this area, going around the tricuspid through this isthmus, and then propagating out to the rest of the atrium, giving rise to this sort of. It's an organized arrhythmia, and because it passes predictably through this isthmus of tissue between the inferior vena cava and the tricuspid valve, you can ablate it, burn it away, and certainly if it's recurrent. Whilst you don't usually do that acutely, if it's a recurrent problem, you bring the patient back into the cath lab and you can burn this area so that the create a conduction barrier within the cavo-tricuspid isthmus, and you don't get flutter anymore. Some of these patients will go on to get atrial fibrillation, however. Next slide. This is a more typical presentation with atrial flutter, I suppose. And you can see if you look at, say, lead V1, V2, V3, or any of the chest leads, it's rather difficult to see the flutter waves. And it's less easy to see the flutter waves even in the inferior leads, but you can just about see them. Once you've seen it, a few times, you kind of get the hang of it. So you can see 2 flutter waves here for every QRS that you're getting. So this is atrial flutter. The rate is usually about 300 beats per minute in the atrium, but unless there's an accessory pathway, only every other impulse will get through the AV node, or even every third impulse, depending on the integrity of the AV node or the drugs the patient's taking. So if you see a narrow complex tachycardia with a funny looking non-existent baseline continuous electrical activity between the QRS complexes, think about atrial flutter and do a 12-lead ECG. Don't try and make a diagnosis based upon one rhythm strip, say in V1. You go to casualty or intensive care, and they'll often try and make diagnoses without 12 leads, but it's very difficult to come up with an accurate diagnosis. Next slide, maybe that's it. That's it. Any other questions?
Doesn't seem
Any
like...
questions on the block, Cameron?
Sorry?
Any questions come in that we haven't addressed?
No, I think they were all they all came in as we were going through things. So yeah, I think that's everything. Wanted to say thank you very much for giving up your time and helping us with the ECG and helping us to understand a bit more about how to interpret it and what's going on.